is muted. All right, let's get started. It's time. Welcome everyone to the session. This is really great to see everybody. So let me kick us to get started. My name is Chia, Senior Product Manager at Edwards Life Sciences Critical Care, Japan and Asia Pacific region. Thank you for taking your time out of your day to join us and invest in yourself. Today, we have prepared rich content for you to see how advanced hemodynamic parameters could help you in your clinical decision making through real cases with experienced clinician. So before the session starts, I do have a little bit logistic that I want to run you through. So today, today we have as the presenter present, you can ask questions through the chat function. So please do spend a minute to locate where the chat button is on the Teams platform. So you can type in the questions anytime during the presentation, but the speaker will only answer the question in the Q&A session. So we're not disturbing their presentation. So please take a minute to locate that. That's really quick for my opening. And without further ado, it's my pleasure to welcome the moderators for today's session, Professor Hong Liu and Professor Yarong Zheng. So, oh yeah, you're on there. Okay, I'll shut up. You guys can take over. Professor Liu, your mic is muted.
Thank you, Jia, for the introduction, and well, it is my great pleasure to participating in this event, and it's it's honored for me to introduce Professor Zheng, who is the director of Department of Anesthesiology at the National Taiwan University Medical Center. She's also a professor of school medicine at the National Taiwan University School of Medicine, and she is specialized in cardiovascular and thoracic anesthesia, just like me. I'm also in cardiothoracic anesthesia. Welcome, and Dr. Zheng, she will be my co-moderator for this session. Welcome.
Oh, Professor Zheng, your mic is muted.
Okay, thank you, Professor Liu. Yeah, I'm Zheng Yarong, and just allow me to introduce Professor Liu. Firstly, I'm happy to receive the invitation to work with Edwards Group and as moderator with Professor Liu in UC Davis. And Professor Liu is the acting vice chair of research in the Department of Anesthesiology and Pain Medicine at UC Davis. And he is also the director of International Partnership of UC Davis Health. And when I look into his profile, I respect him as his philosophy, which that I treat my patient the same way I want to be treated. And Professor Liu has published hundreds of reports on basic and clinical research. His research area include perioperative hemodynamic monitoring and high-risk surgery outcomes, including the recent report with COVID-19. And thank you for invitation from Edward Group. Okay, let's move on to the speech.
Thank you, Dr. Zheng, for your introduction. So today's agenda, we will have 4 speakers who will talk about a different subject, and at the end we will have a Q&A session of it. I think maybe at the end of each presentation, we can have a few questions also, just so to be the continuity and make sure people don't forget. And so this is today's program. So we will have Dr. Zhen to introduce the first speaker.
Okay, let's move to the second slide. The slide of Dr. Lai Zirun. Just wait a minute. Okay, let me introduce Dr. Lai Zirun. Dr. Lai is an attending physician in National Taiwan University Hospital, and she is also a PhD student in Institute of Epidemiology and Preventive Medicine in National Taiwan University. And as anesthesiologists, we all know that intraoperative hypotension is crucial for perioperative outcome. However, we are so happy to have some monitors to predict it. However, the cost benefit is still seriously concerned. So Dr. Lai will give us her talk, starting with a mini review with previous reports and followed by her own research on the intraoperative operation and intraoperative hypotension and the postoperative outcomes with or without HPI. So welcome, Dr. Lai. 可以开始了。
Hello everyone, my name is Zhirun Lai. I'm an anesthesiologist in National Taiwan University Hospital. My research topic is the effect of applying hypotension prediction index guidance during major surgery for decreasing the duration and severity of intraoperative hypertension and postoperative complications. It is a randomized control trial. The most common used definition of intraoperative hypertension is the mean arterial blood pressure lower than 65 milliliter mercury. The incidence of intraoperative hypertension is 91%. The most important intraoperative hypertension risk factors is the major surgery, which is defined as a surgical duration longer than 2 hours or estimated blood loss higher than 500 milliliter. The prevention of intraoperative hypertension is important. The major surgery is regarded as one of the most important risk factors of intraoperative hypertension. Because of the surgical duration longer than 2 hours and the estimated blood loss higher than 500 milliliter. Many postoperative complications are associated with intraoperative hypertension, including stroke, acute myocardial injury, or anastomotic ischemia. Decreasing the intraoperative hypertension occurrence could decrease the postoperative complications. In previous studies, postoperative mobility survey is used to evaluate the organ functions systemically. The items include 8 items such as pulmonary function, complications of cardiovascular, renal, gastrointestinal, neurological, infectious, wound and blood transfusion, as well as increasing pain. The researchers obtained the data of organ functions from the medical record, patient self-reported question, or lab data. Hypotension Prediction Index Monitor has been commercially marketed in 1920. HPI is short for Hypotension Prediction Index. The HPI algorithm on the Acumen HPI software system uses the features of arterial blood pressure waveforms, including amplitude, area, segment slopes, and the complexity features to predict intraoperative hypertension, defined by mean arterial pressure less than 65 milliliter mercury for at least 1 minute. The range of HPI value was from 0 to 100. The higher levels indicate a higher likelihood of trending intraoperative hypertension. The HPI has been reported that the values of sensitivity to to predicting intraoperative hypertension 5 minutes, 10 minutes, and 15 minutes in advance were 0.92, 0.89, and 0.88, respectively. The values of specificity were 0.92, 0.9, and 0.87 in advance. The study of Shin et al. Applying HPI guidance in cardiac surgery, including chest opening condition, also showed good sensitivity and specificity. The sensitivity for predicting intraoperative hypertension 5 minutes, 10 minutes, and 15 minutes in advance for 0.69 to 0.89. The specificity was from 0.75 to 0.88. The area under the curve was from 0.79 to 0.92. Basic equipment is the A-line and the HPI monitor. Here is our video. The video presented the HPI.
It's okay. Just go through it.
I think Dr. Lai is probably resharing her screen. Oh. I think she's having some problem with the computer. Hey, Steven, you can share from your computer too if you want. Oh, wait. Technical issue.
And Dr. Lai, it's always happen. Just go through it. Yeah.
现在看到吗？
Yeah, we can see.
The video presented the HPI alarm because of the data higher than 85.
It works.
The HPI alarm because of the data.
So, Stephen, are you sharing your screen now?
The video presented the HPI alarm because of the data.
Okay, now got it. Yeah.
Did you see it?
Did you see it?
Yes,
Yeah, the presentation's up now.
yeah. The presentation came out. Yeah.
In recent studies, the investigators usually use a variable, time-weighted average mean arterial pressure less than 65 milliliter mercury, to present the severity and the duration of intraoperative hypertension. This is one of our patients. The figures show the area under the mean arterial pressure lower than 65 milliliter mercury. The unit of the value 852.8 milliliter mercury is a milliliter mercury times minute. It represents the total area under the receiver operating characteristics curve lower than 65 milliliter mercury. It is true for AUC. Total surgery duration is 535 minutes. The AUC divided by surgical duration, making the data of time-weighted average mean arterial pressure less than 65 milliliter mercury, was 1.585 milliliter mercury. This here is our research strategy. This is the flow chart for literature review. 3 randomized trials were found. We presented them as follows. There are 34 patients in HPI group and 34 patients in the standard of care group. The definition of intraoperative hypertension is the mean arterial pressure lower than 65 milliliter mercury. The primary outcome is time-weighted average mean arterial pressure lower than 65 milliliter mercury. The results presented that the data of time-weighted average mean arterial pressure lower than 65 milliliter mercury in the HPI group is significantly lower than the standard of care group. There are 105 patients in HPI group and 105 patients in the standard of care group. The definition of intraoperative hypertension is the mean arterial pressure lower than 65 milliliter mercury. The primary outcome is time-weighted average mean arterial pressure lower than 65 milliliter mercury. The results presented that the data of time-weighted average mean arterial pressure lower than 65 milliliter mercury in the HPI group is comparable to the standard of care group. The postoperative complications presented no significantly difference. There are 49 patients in the HPI group and 50 patients in the standard of care group. The definition of intraoperative hypertension is the mean arterial pressure lower than 65 milliliter mercury. The primary outcome is time-weighted average mean arterial pressure lower than 65 milliliter mercury. The results presented that the data of time-weighted average mean arterial pressure lower than 65 milliliter mercury in the HPI group is significantly lower than the standard of care group. Here is the research gap. The HPI effect in previous studies were inconclusive. The postoperative complications have not been well followed. The aim of our study is to investigate the ability of applying HPI guidance to decrease the time-weighted average mean arterial milliliter mercury compared to no HPI guidance. The postoperative complications have been also followed. Our study is a randomized trial. The study is performed in National Taiwan University Hospital. Our patients will meet the following criteria. The age older than 20 years old. They all receive elective major surgery. The exclusion of patients with arrhythmia or major organ dysfunction. This is our procedure. All patients were inserted arterial line with HPI sensor. In the HPI guidance group, there were 6 choices in the hypertension management when HPI is higher than 85 and above. In the standard of care group, patients were treated as usual care when the intraoperative hypertension is noted. This is our protocol in the HPI guidance group, just as a previous study of Maheshwari et al. This is our protocol of intraoperative hypertension treatment. Here is the new variables in the Acumen HPI software system, including delta P divided delta T and dynamic arterial elastance. The delta P divided delta T represented the cardiac contractility. The dynamic arterial elastance demonstrated not only to predict an increase in mean arterial pressure after fluid administration, but also related to arterial stiffness. When HPI alone, the stroke volume variation was identified. The stroke volume variation was higher than 13. Then the parameters indicating the afterload including systemic vascular resistance higher than 800 or dynamic arterial resistance lower than 0.9 will be identified. If the intraoperative hypertension resulted from hypovolemia and low afterload, and the crystalloid will be administered. If the parameter indicating the cardiac contractility, delta P divided by delta T, was lower than 400, the ephedrine will be administered. If the intraoperative hypertension caused only by hypovolemia, the fluid administration was administered. If stroke volume variation was not higher than 13, the main cause of intraoperative hypertension will also be identified and will be given the right treatment at the right time. The definition of the parameters related to ROC analysis. Hypertensive events define the mean arterial pressure lower than 65 milliliter mercury, estimated under the threshold and the duration of monitoring as previously mentioned. A non-hypertensive event was calculated by identifying a 30-minute continuous section of data points, such that the section was at least 20 minutes apart from any hypertensive event, and all data points in that section showed mean arterial pressure higher than 65 milliliter mercury. A non-event or negative data point was the center point of the non-hypertensive event. A true positive was regarded as any hypertensive event with HPI value greater than the value of 85.
Hey, Steven, would you mind just stop sharing the camera? Because I think the audio, the quality is not very stable.
Positive predictive value was calculated as a number of true positive events divided by all positive ones. Negative predictive value was the number of true negative events divided by all negative ones.
Did you see?
Yes, yeah.
Our primary outcome is also the time-weighted average mean arterial pressure lower than 65 milliliter mercury. The secondary outcome included time-weighted average mean arterial pressure lower than 55 milliliter mercury and the AUC mean arterial pressure lower than 55 and 65 milliliter mercury times minute. We also recorded the perioperative variables. The postoperative complications and mortality have been also followed within postoperative 30 days. Our continuous outcomes were calculated by two sample t-tests or Mann-Whitney-U test. Our binary outcome were calculated by chi-square test. It's our sample size calculation. There are 60 patients in the total group with 1-to-1 ratio. Here is our demographic data in both groups. No significantly difference was shown in both groups. The surgical duration was longer than 8 hours. The time-weighted average mean arterial pressure lower than 65 milliliter mercury in the HPI guidance group is significantly lower than standard of care group. The following three tables presented the intraoperative factors in comparisons of HPI and the standard of care group. The colloid higher and equal to 500 milliliter, RBC transfusion higher and equal to 2 units using platelet transfusion. Estimated blood loss higher and equal to 350 milliliter, and the urine output higher and equal to 1000 milliliter presented significantly difference between both groups. The use of the use of nintedanib and labetal between with or without the HPI guidance presented no significantly difference. No difference between the hospitalization and the ICU days. One patient in the standard of care group died at postoperative day 13. He died from arrhythmia, anastomotic leakage, and pneumonia. Presented postoperative complications. The lower occurrence was noted in the HPI group than in the HPI guidance group shows a short post-operative mobility system of post-operative mobility survey. Its name was POMS. The occurrence of post-operative composite complication was one of complication occurrence recorded for POMS. The post-operative pulmonary complications, gastrointestinal complication, and wound complication has significantly lower HPI guidance group than in non-HPI guidance group. The y-axis is complication absent probability. The x-axis is the following day. The patients with HPI group had higher complication absent probability than in patient without HPI group does. We present the composite complication, pulmonary complication, GI complication, and wound complication in the figure. After controlling other intraoperative clinical variables, including colloid, crystalloid, blood transfusion, FLP transfusion, and et al. These factors, using HPI could provide a protective effect for postoperative complications occurrence. The hazard ratio is 0.23. No interaction was noted between using a colloid higher and equal to 500 milliliter, blood transfusion 2 units, no FLP or platelet transfusion, higher urine output, using norepinephrine, no using ephedrine, no using nicardipine or labetal. The first studies needed more investigated. This is our data of our analysis. Our sensitivity, specificity, positive value for 5 minutes predicting intraoperative hypertension is good, which are from 0.68 to 0.93. We also calculated the kappa between the following HPI guidance protocol and actual management. Our kappa was 0.64. This is our main finding. Patients under HPI guidance with significantly lower value of the time-weighted average mean arterial pressure, less than 55 and 65 milliliter mercury than no HPI guidance. Patient under the HPI complications within postoperative 30 days, including pulmonary wound and gastrointestinal complications that postoperative complications. Our main result of time-weighted arterial pressure less than 65 milliliter mercury was similar to previous study of Weinberg and Tanzumba et al. Our result is different from the study of Maheshwari et al. Lower postoperative complications in HPI guidance were noted in major surgery. In previous studies, maintaining higher blood pressure caused lower postoperative complications. Our data of sensitivity, specificity, area under curve, positive predictive value, and negative predictive value predicting intraoperative hypertension in 15 minutes was similar in the study of Shin et al. The clinical strength of HPI guidance could provide a clinician of intraoperative hypertension at the right timing. One of our limitations is the lacking generalizability. The other limitation is our treatment algorithm is not based on expert clinician opinion and available evidence from Maheshwari et al. However, our study following the algorithm proved a great clinical outcome under good compliance, so the concern was eliminated. Applying HPI guidance for intraoperative hypertension prevention compared with non-HPI guidance resulted in less intraoperative hypertension and lower postoperative complication. So further studies with larger surgeries fully assessing safety, generalizability, and cost are needed. Thanks for your attention.
Okay, thanks for the interesting and impressive talk of Dr. Lai. Thanks for our dear friends online. Do not hesitate to type your question on the chat box and let Dr. Lai respond to you directly. Until now, there's no question, so allow me to give a few comments. I think this is not from the positive result is not come from with applying HPI, but with timely and accurate response to high HPI value. And the result on outcomes, as your result, applying HPI and response with high HPI present less intraoperative hypotension with more fluid, more blood transfusion, and more urine output. However, the outcome shows the HPI group have significantly less pulmonary, gastrointestinal, and wound complications, but not acute kidney injury. And what do you think about your result on this outcome, especially for acute AKI? So Dr. Lai, please. Hello, Dr. Lai.
Hello. I think in my results and during my ongoing study about HPI, I didn't find no difference between the AKI in the postoperative period. I found the most interesting is the postoperative pulmonary complications. Just as the new finding in the HPI, applying HPI group is the most postoperative complications, especially in major surgery. In the short name, we call it PPC. And the definition of PPC includes atelectasis, bronchospasm, respiratory distress, pneumonia, acute lung injury, and respiratory failure. So, in PPC study of Nito et al., they found that intraoperative use of vasopressor is a risk factor of PPC.
Dr. Lai, and there are some questions from the chat box. And the first one is about, is this research published or not? Please answer it, Dr. Lai. Is your research published or not?
No.
Not yet?
Not published.
Okay. And I think you should turn, and the next question is from the chat box is about your result. So I think please show your HPI management strategy. The next slide, yeah. Hypotension management. The slide, hypotension management, and to show your strategy to manage by HPI guidance. Yeah, this one. So please introduce deeper, because some of our audience, they want to know the strategy.
My strategy is from the Mahashuveri et al. Studies, referencing from his study. And this is our protocol. And the special new variables in the Acumen HPI software system, including delta P divided delta T and the dynamic arterial elastance. And the delta P divided delta T presented the cardiac contractility. And dynamic arterial elastance related to arterial stiffness. So in the software system, HPI along the stroke volume variation identify, and the stroke volume variation higher than 13, then the parameter indicating the afterload, including systematic vascular resistance higher than 800 or dynamic arterial resistance lower than 0.9 will be identified. if intraoperative hypertension resulted from hypovolemia and low after load, it will be administered. If the parameter indicating the cardiac contractility, delta P divided by delta T was lower than 400, the ephedrine will be administered. If the intraoperative hypertension caused only by hypovolemia, the fluid administered was given. If current variation was not higher than 13, the main cause of relative will be also identified in the other side and be given the right treatment at the right time.
I have a question, Dr. Lai. So, how many patients you put a central line there? Because you have SVR here.
All patients, I put a central line.
All the patients?
Okay. Yes, all patients.
So
Because
what
this-
is, sorry.
Excuse me, you please.
Oh, what is the difference like between the time of average the map versus the conventional map? You know, I mean, because for most of the time people in intra they just look at the map. What's the difference between those?
Important is time-weighted average mean arterial pressure present the severity and duration of the hypertension. It has just like exposure to intraoperative hypertension.
I'm sorry to step in, but we're running behind the schedule. I'm wondering if we can move on to the next presenter, and if we have more time in the end, we can come back to address those questions.
Okay, thank you, Dr. Lai. And I'll move on. Yeah, please, Professor Liu.
Thank you. Okay, so it's my pleasure to introduce next speaker, Dr. Fancy T or Dr. Morocco. So I don't know. I'm sorry if I pronounced the inaccurately. However, Dr. Morocco is a anesthesiologist, intensive care doctors, and he the committee members of Thailand Society of Critical Care Medicine, and also is the committee member of Royal College of Anesthesiologists of Thailand. And he is going to share with us his experience and study on the HPI. And here, please, Dr. Morocco.
Okay. Thank you, moderator, for introducing me. And then I would like to thank you, Edward, for inviting me to participate this conference today. Now I'm going to present and share an Acumen IQ sensor case presentation. This case is a 68 Thai years old male, body mass index around 26, and comorbidity are diabetic mellitus, dyslipidemia, and hypertension well controlled. Baseline blood pressure is around 120, and his medication is manidipine. His diagnosis is liver cell carcinoma, right lobe, and right anterior sectionectomy is the operation today. This is his basic laboratory investigation. It's all within normal limit, including CBC, renal, and function tests. As we already know that traditionally, a low-speed strategy has been used to reduce venous bleeding. And low CVP is the clinical standard for fluid therapy during major liver surgery. From Galileo trial, low CVP was not associated with perioperative directed therapy in intraoperative loss, major morbidity, and quality of surgical field. However, although PGDT has been associated with reduced morbidity and mortality abdominal surgery, concern or not when applying PGT in liver surgery. From this case, this is not the presentation case, but in this case, it's a tectomy case. Low CVP strategy was done during liver resection, but 3 hours later, CVP increased after adjust the reaction and packing in abdominal packing. And anesthesiologists add more and more tools CVP. But I think, in my opinion, now CVP remains reliable and hypotension occur frequently. So in low CVP study, I think hypotension may be a price to pay. From this case, hypotension, time in hypotension occur about 93 minutes and or 20% from all procedural time, and 23 events measure mainly during they try to reduce CVP. From point-2 trial, we know that new onset of hypotension occur during intraoperative. For point-2 trial, around 35% is a new onset hypotension. And very important of hypotension was 10 minutes increase in hypotension, 9% in morbidity, composite the infarct. So hypotension should occur. From study, they try to evaluate